Welcome to the Homegrown Heart Podcast, every Friday at 7 a.m. Mountain Standard Time, with your host, Dr. Amanda Ryan, D.O., MBA, interventional cardiologist, and an expert in her field. This week's topic, equity and PAD, how we can change the tide. Please help me welcome our host, Dr. Amanda Ryan.
Good morning. It's a nice September day here in Carlsbad, New Mexico, and I'm your friendly interventional cardiologist, Dr. Amanda Ryan. PAD Awareness Month continues in September. I hope you caught our podcast last week where we were introducing you to peripheral arterial disease, talking about some of our screenings. We had a screening in Carlsbad actually on Wednesday, and we didn't have a whole lot of people come. I mean, you just never know. Sometimes you get a lot of people, sometimes you don't get that many people. But wow, a couple of the people we did get. We got a patient and I asked, they didn't mind if we talked about their case. Multiple blood clots in their legs, blockages in the arteries in their legs also, was getting care, but not really the type of care that they probably needed. Were not taking any blood thinners despite having been multiple blood clots as well as blockages in their legs, and had some wounds, and my staff was very excited about the opportunity to really help that person. So I'll just be totally honest, if we had that one person come to our PAD screening, it would have been worth it, because that's what this is really about. That is somebody that truly needs quote unquote limb salvage. We're talking about losing a leg. And what is the relevance of that and the importance of it to our overall health? I mean, obviously, I have a lot of patients in my office sometimes that have relatively asymptomatic disease of their legs, or they think they're asymptomatic, by the way, because they really don't walk because their legs hurt them. But when I start really talking to them like, look, I'm not the doctor to push you to do things that you're not comfortable with, but ignoring this can truly end up leading to amputations. And I can't tell you how many times the people say to me, that's what happened to my mom. That's what happened to my grandpa. That's what happened to my uncle. And I'm always like, wow, I mean, I don't have any family members who've had limbs amputated with diabetes and smoking and significant blockages. I've dealt with other things. I've talked about my extensive heart history in my family. My grandfather did have significant PAD, though. If you remember the Grandpa Jim story, he actually died from a ruptured abdominal aortic aneurysm. Abdominal aortic aneurysms are also part of PAD, again, peripheral arterial disease. We classically think of the blockages in our legs being peripheral arterial disease, but it really does mean blockages anywhere outside the heart. That can include our carotid arteries, in our aorta, in our abdomen, in our kidney arteries. There's a lot of other places that we can get blockages. So my grandfather back then had an aneurysm. We call it a AAA, if you ever heard the term AAA. So with the AAA, we know they can rupture when they get about 5 centimeters. And my grandfather's AAA actually got to 9.5 centimeters. I don't really know why we kept measuring it, honestly, because I was in college when he passed away. I think I mentioned he was really trying to hold on there till I graduated from college. And I had a little bit of knowledge then, and I knew I wanted to be a cardiologist. I didn't know why we kept measuring it, because we didn't have these fancy EVARs, they're called. We fixed AAAs now up through the groin, and we have for years. But back in those days, which I guess I'm kind of dating myself to here, but let's call it the late 90s, we were not able to, we weren't advanced enough to put these stent grafts in up through people's groin. And I'll show a couple slides of that on the podcast as well, so you can see what I'm talking about. But it's basically a stent with covered mesh, like white covered mesh. And it's going to, an aneurysm outpouches like this of your aorta. And unfortunately, as the blood keeps going in these outpouched segments, eventually it can actually weaken the wall of your aorta so bad that the aorta ruptures. So you might have heard the term before, a ruptured AAA. that means that you'll start bleeding, and the aorta is located retroperitoneal, so literally back by your spine. But it's very hard to get to it in an open surgery. So if you see someone that's had open aortic surgery, when Bob was here, he showed his scar. Your scar is stem to stern, and all of your bowels and all of your organs have to be moved to get back to your aorta. Well, if you rupture an aorta where the 5-6 units of blood that we carry in our body are all located, you will literally bleed out in minutes. And that is what happened to my grandfather. His heart was too weak to sustain a major surgery, and so he ruptured this AAA, and he knew it. He sat on the bathroom. My 16-year-old cousin was living with him at the time. Again, one of the only 2 boys out of our 16-person grandkid clan. At a really pivotal moment in his own life, and unfortunately, it's caused him a lot of stress and strain over the years, that what he really did go through with my grandfather in those last several months of his life. You know, they were trying to be a support to one another, but it's a lot to bear for a 16-year-old. And my grandfather sat on the toilet and said, "I have the worst abdominal pain of my life. I think this is it for this aneurysm." And he died. And technology is a beautiful thing that has advanced so far in today's day and age. My grandfather would have had a different outcome from that. Now, Grandpa was going to continue to smoke and probably block up something else. And I had mentioned his heart ejection fraction was about 5%. So I'm not saying that, unfortunately, we're all passing away at some point. But the quality of life that we have while we are here is so important. And so is really having these advanced technology options available to us. And so when we talk about that, thinking about peripheral arterial disease and who has access to what, again, as my view of life and the world have evolved over the years, as I've had a lot more exposure, I've really kind of widened my view. I'm a public school kid. My mother had me when she was a teenager. I feel like I've accomplished everything in life up to this point that I wanted to, and I have a lot more that I hope to accomplish. So I sometimes think I did have a little bit of the idea that we all can do whatever we want to do. We all can get access to good health care. We all can go to good colleges. We all can, they'll loan you the money. Like, it may not be the same based on your socioeconomic background, but we do all, quote unquote, have the same opportunities because this is America. And I don't really think that anymore. It's not that I think we can't get the access, but we have to work together. We have to partner as communities, as healthcare providers, as lay people, and really figure out where the disparities are. And I'll speak specifically to healthcare, but I think my opinions carry over to education and a lot workforce and a lot of different industries. But I'm going to stick specifically to healthcare in this, in this segment. How do we get those people that are more vulnerable to get the kind of care that they need? A couple statistics I wanted to go over this morning. Women present for revascularization at an older age compared to men. So that's an interesting, I see that in my practice. I have some 85-plus-year-old females who have never smoked, who do not have diabetes, and they end up with significant blockages in their legs. I have one particular patient I'm thinking about that I've sent to Dr. Raja several times in El Paso before we really had our own program going. And she would really try to walk in between a very functional 88, 89-year-old lady, but just blockages in her legs to the point where it's almost crippling for her with the pain. And so it's sometimes, non-smoking, non-diabetic, older patients do get blockages in their legs. So it's often in those younger people, the risk factors are important. But as we get older, we're actually all at risk of peripheral arterial disease, not just those who have diabetes and smoking, poorly controlled cholesterol, etc. The prevalence of PAD in Black people is approximately twice that of white people. Now that is a very high prevalence. That means if African Americans are 11 to 14% of the population, that they may represent up to 28 to 30% of the PAD population. So that means, which it's very common. I think we've got, again, 10, 14 million people living with significant peripheral arterial disease. So with that being said, how do we reach our African American population? I talked to a few of my African American patients last month, actually, as we geared up for PAD awareness, who have PAD and significant blood pressure issues and diabetes. And we were kind of discussing, the fact that women and minorities of all backgrounds, but particularly Hispanic and African American, are lacking in our trials. Cardiology, the vascular surgery world, we have all kinds of trials that we figure out. But again, it's overly represented by white men in our trials. And thank you to our white men who are participating in the trials, because at least somebody is. But then we're trying to extrapolate all that data to the same as everyone else, and there's times when that's not true. Again, there was a large cardiology trial, I think I mentioned it at one point, called AHEFT, but it actually showed in some heart failure treatments that were coming around. Again, this was late 90s, early 2000s. But what we had found in our Caucasian population was not working for our African American population in the same way. And we actually changed our heart failure medication recommendations back then based on your background. But again, if we don't have people represented in those trials, then we can't really, we don't really know. So all we can do is extrapolate the data that we do have. So if women aren't represented and Hispanics aren't represented and Asian culture, people from many different Asian cultures, again, everything from Korea, China, Japan, India, Pakistan, we need people represented from all, America is a melting pot. Not only are we talking about research that often goes on worldwide, but even when you're just looking in the United States, we have people from all different cultures living here. And as part of that, we really have to make sure we have guidelines that accommodate for all these different backgrounds. But that really starts with getting them involved in our research. So that involves building some trust. I mean, why in some, I'll speak specifically to the Black population. They have a right to have mistrust of trials. It's Jewish people, getting them involved in trials, those with a Jewish ancestry. After what they have been exposed to during World War II times, obviously being used as guinea pigs for all kinds of different research projects, they are very hesitant to want to be involved in any quote-unquote traditional research. So with that being said, we have to build trust within our communities. We have to reach out to one another. We really do need to break down these barriers that make us prejudge people based on their race, religion, skin color, backgrounds, and realize that from a healthcare standpoint, we've got to all work together. A few other peripheral arterial disease amputations are 2 times more common in our Black and Hispanic populations than our white population. Not only is the disease 2 times more common, so are your opportunity, or opportunity is definitely a bad word, your reality of being at risk for an amputation if you are Hispanic or African American is much higher than if you are Caucasian. Eliminating disparities in PAD requires interventions that include improvements in education, access to care, and changes in health policy. I read an article this week on the business side of healthcare about what are healthcare leaders tired of hearing? And I think I spoke to this last week a little bit too, but workforce shortage, system interoperability, and social inequities of health. We say those words and we're trying to value-based healthcare. I'll throw that in too. We hear these words at all kinds of conferences, at all kinds of different, and we've been hearing them for a good 5 to 10 years. but I don't necessarily see where we're making the progress, and again, I think I spoke to the new healthcare high school in Houston that Hernan Memorial is getting going. They're a large system. I think that's great. I'm excited to see how that turns out. But that's just one thing. Again, there's a very large PAD awareness program called Close the Gap that a large industry provider, Boston Scientific, supports. As part of that, it is really identifying. We can run our Medicare data. This is available to everyone, but we can run our Medicare data based on CPT codes. So again, here I'm going to say any procedure that is done to a patient or a test that's ordered has a 5-digit, what's called a CPT code. Okay, that kind of says an echocardiogram, CPT code 93306. Then insurance companies, including Medicare, federal government, Medicaid programs, and private insurers will say if you want to do a 93306 on a patient, there must be certain ICD-10 codes. ICD-10 codes are a complex, somewhere between 4 to 6 number letter combination that says what symptoms or disease process do you, the patient, have that justifies you getting this test. Make sure, like I was telling some of my newer staff yesterday, the complaint can't be foot pain and we're ordering something for someone's eyes, right? Things have to make sense. Okay, so we have to make it make sense. As part of that, that allows those ICD-10 codes and CPT codes that are posted for billing purposes can be tracked. We can track in all of Southeast New Mexico and Eddy County and Lee County and Chavez County, New Mexico as a whole compared to Texas, we can do all kinds of comparisons of the number of people with certain diagnoses and the number of procedures they're getting, what medications they're on. So there's really large tracking tools out there. There's so much available though, we have to be able to act on it. And I will tell you, when I worked with Boston Scientific on that Close the Gap program, what I did see was huge disparities in New Mexico in general, let alone the different populations within New Mexico, of really identifying their peripheral arterial disease and treating it appropriately, as well as a very high rate of amputations compared to several of our neighboring states. Again, I work with Dr. Raja, and you'll hear me say his name a lot. He is an amazing peripheral vascular interventional cardiologist in El Paso who's really made a career decision and passion to treat leg blockages. And when I tell you this man and his team are out there fighting, they do Fridays in the hospital in Providence, Sierra. They're difficult cases. They often work from 7 a.m. until midnight on Fridays, and that may only be 4 or 5 cases. They work those kind of hours doing what they can to open up leg blockages in people. And why? Because their overall mission is to prevent amputations. Because they are getting the patients that are at that severe level of disease, that if we cannot improve their blood flow, we cannot heal their wounds, they will start with a toe cut off, half of their foot cut off, below their ankle cut off, below their knee cut off, above their knee cut off. Even I didn't have I used to think, well, if you did have an amputation, if it was that bad and you had what we call gangrene in your leg and it got cut off, that was it. You just got it cut off and you learned to deal with it. Bad, but oh no, that is not the end of the story. Whatever the amputation is, if we don't even get blood flow to that area, then that quote unquote stump will not heal. So then you amputate further back and further back again. It's just overwhelming when you really think about the implications of that. Also, within 5 years of that first amputation, oftentimes the other leg, 50% of those people will have the other leg amputated. And it is completely debilitating to somebody to be a double amputee later in life in particular, secondary to poorly treated peripheral arterial disease. And it does happen. Dr. Raja and his team at Sierra Providence are one of the first 2 hospitals in the country, actually, to institute a program where an angiogram is absolutely required prior to having an amputation. Amputations of the toes, feet, that could be handled by podiatrists who are specifically foot and ankle trained, orthopedic surgeons, vascular surgeons. As part of that, sometimes we end up doing amputations and we're not really making sure the blood flow to each segment is as good as possible. Or honestly, even if we do know we don't have great blood flow, we're located in an area that doesn't have a Dr. Raja, that doesn't have an advanced ambulatory surgery center of Carlsbad, New Mexico. And make no mistake, that is a major reason why my team and I and my partners embarked on this journey to bring this top-level surgical center to this area. We did not have the capabilities at any of our facilities to do what we are truly doing at our surgical center. We have a lab specifically designed to treat leg blockages. We have very high-end equipment. Again, there are probably 4, 5 ways that you can clean out plaque in the legs called atherectomy devices, and we have 3 of them at our facility. Now again, we have options where if we've exhausted those choices, we get you to Dr. Raja, we get you to Dr. Paoni and his team over in Lubbock, we get you to El Paso, we get you up to Albuquerque, to Dr. Profit and their team up there. All of our major centers around do have good physicians who can take it another level if we're not able to help you. But overwhelmingly, and Dr. Thigman has been treating leg blockages in our community for a long time. He has so many other, like me, so many other realms that he does as well. But we do our very best. But by the time people present to him or I, we're often looking at entire thigh arteries blocked, only 1 vessel going out to the foot when we like 3 vessels to go all the way out to the foot. And I'll show that slide again. What should blood flow to the leg really look like compared to what it can look like whenever you don't have good blood flow? And again, what causes these disparities in outcomes of peripheral arterial disease? Like really, what is the problem? There's just unequal access to optimal care. As I said, open up your eyes in the same way I have. We do not all have the same access to care. Now, I grew up in a rural area. My grandfather had to go 3 hours to a decent cardiologist. I obviously knew that we don't all have the same equal access to care. Can you get there? Maybe, but you're going to have to go 3 and 4 hours. If you're in a city, you may have to go 15 to 20 minutes. However, everyone in cities does not get the care they need either, and there are several factors there as well. It isn't as though distance is the only factor preventing people from getting where they need to go. Racism, poor knowledge and awareness, sexism, and wealth inequities. Those are all realities in our healthcare system. They are realities in our society, and they absolutely affect access to care. PAD is a particularly vulnerable place where they affect it. Based on your geography, your socioeconomics, your race, your sex, your access to care, there is an underdiagnosis of PAD. There is a poor functional performance. There are increased rates of cardiovascular events and increased rates of major adverse limb events. That's just true. So we've acknowledged, I think we're all at a point where, and within healthcare, where we do understand that. The question is, what are we going to, what can we do to change it? Again, overall, 7.2% of people age 40 or over have some degree of peripheral arterial disease. That's a pretty high percentage when you think about it, 7%. Probably even higher now, to be honest, because the data is always a few years old by the time it makes it to a research trial, which I'm reading from. The incidence of PAD is similar in men and women. Men might have more severe PAD than women at a younger age. Women also have lower ABIs oftentimes than men do. What are ABIs again? Again, ABIs are that basic screening test where we put blood pressure cuffs on your arms as well as your legs, and we can do things called segmental. We have several blood pressure cuffs, and we check the difference. That should be a ratio of close to 1. Your blood pressure in your arm and your blood pressure in your leg should be relatively similar. There really shouldn't be a significant difference. If it gets 0.7, 0.6, 0.5, that ratio, meaning your blood pressure in your legs is a lot lower than your blood pressure in your arms, somewhere between point A and point B, you probably have a significant blockage. So that tells us, hey, we need to go on to the next test. But that is such a basic, I mean, it is a $70, if you have any diagnosis whatsoever, high blood pressure, high cholesterol, if you have any symptom like pain, like fatigue, arm pain, any of those symptoms qualify for doing a basic ABI. It is almost like just our podiatrists are so good about doing it. If you go to them for anything, they'll be like, I think we should probably check your ABIs in your legs. Thank goodness for our colleagues in that realm, Dr. Folsom, Dr. Krupa, Dr. Katie, Dr. Chow, they're actually checking for ABIs. Dr. Ball over in Roswell, who's amazing. Really important that we check for these things. That way we know that then we need to look further. But I can tell you the overwhelming, in our primary care offices, we should be doing ABIs. We should be doing them on our patients. But, anytime something is a screening test too, it's kind of, you have to get people in the mindset of, why is this necessary? So many people have never even really heard of PAD or blockages in their legs, or they don't realize that they're at risk. So they're kind of like, I don't need that. Same as an EKG. I mean, it's such a basic heart screening test. It's so useful if it changes. And I can tell you how many people in my office, like 75 or 80 years old, and they come to me because of a quote unquote abnormal EKG, and they've never had one, so we don't really know if it's new or old or changed. So some of these screening tests, I promise, if Medicare and the federal government have said it's okay to do it as a screening test, it's definitely okay to do it as a screening test. So definitely, if you have any of the relevant diagnoses, we really do need to check for PAD in these patients. So I think that's really, today I'm going to kind of close up with that. This was a quick segment on PAD, some social inequities, the difficulty in getting the care that you need from a PAD standpoint. I really focused on the diagnosis and awareness and those disparities. Our practice continues to be mission-driven. Partners in Heart Health is our foundation. Again, we're having an amazing event, a casino night on the 14th of September at the venue here in Carlsbad. Please get with Tammy Wacker. We'll again be putting up our information on the podcast. On the 21st of September, we have a heart walk in Hobbs. Walking is one of the biggest treatments for PAD that exist. Whatever fancy equipment I can jackhammer through your legs, you've got to walk. So if you're in our Hobbs area, if you're one of our patients, if you're not one of our patients, if you have any kind of peripheral arterial disease, coronary artery disease, join us the 21st. Come out there and walk. You don't have to run a marathon. A good walking program for a PAD patient may literally be walking 3 to 5 minutes. Get out there and walk 2-3 minutes. I've got a patient yesterday who has significant PAD, told me how he's walking about a half a mile in 30 minutes. And he was thrilled with that. And I was thrilled for him. And he's a younger 55, 60-year-old gentleman. And normally, it didn't seem like walking half a mile in 30 minutes is that great. But we're all at our own pace. Your race is against you. Your judgment is against yourself in the sense of, I wasn't walking at all. I'm walking a half a mile. It doesn't matter how long that takes me. I'm trying to prevent my legs getting cut off. 30 minutes. And by the way, his cigarettes went from 3 packs a day to 0 packs a day. Over the last 4 years, he has completely stopped smoking. That's success. That's why we do what we do. That's why we sacrifice time from our families. And we're here for you. at Advanced Heart and Vascular Center of New Mexico, Advanced Ambulatory Surgery Center of Carlsbad, New Mexico, and Partners in Heart Health. Please continue to partner with us. Thank you, our community supporters. The casino night has so many amazing prizes. This is going to be just a super event. So please get with Tammy Wacker, and we hope to see you guys at all our events. Thank you.